All right. So thank you for joining the Ohio ACEP Fellowship Zoom. Today's Zoom will be focused on ultrasound fellowships. So our resident advisory group identified this as an important topic, and I'd like to thank all of our panelists that have joined us today. I'd also like to thank the chair of our Candidate Young Physician Committee, Dr. Bob Jones, as well as our Ohio ACEP resident board member, Dr. Megan Ladd. So Dr. Ladd is going to begin the conversation to get us started, but please feel free to chime in, chat, or raise your hand and ask questions. This is an informal, informational Zoom. So I'll hand it over to you, Dr. Ladd.
Yeah, I also wanted to thank you all for coming. I'm pretty excited that we'll get this kind of educational opportunity rolling. The first thing I wanted to do was have the panelists introduce themselves, where they're at, and kind of what they love about ultrasound.
So we want to start with Dr. Stoltz. You're first on my screen.
Okay, excellent. Hello, I'm Lori Stoltz. I am the division director at the University of Cincinnati and currently the fellowship director as well. What do I love about ultrasound? I mean, what is there not to love? I think the main love is that it makes me a much better doctor. It makes me better at what I do.
And just going down my screen, Dr. McCafferty.
Hey everyone, I'm Lauren McCafferty. I'm one of the residency APDs as well as the ultrasound education director at University Hospital's Cleveland Medical Center in Cleveland. Similar to Lori, I think ultrasound makes me a much better doctor in every sense, better diagnostically, better procedurally, and I feel like I can educate my patients a little bit more than I would just with words. So all around, ultrasound is a win.
All right, and Dr. Ellen, I'm going to say your last name wrong, so I'm going to let you say it.
It's free. The H is silent.
Okay.
I am at Ohio State University finishing up my residency, and I'm going to be staying there for fellowship. So I'm super excited about that. I love ultrasound. I agree with Dr. Stoltz. I feel like it makes me a better doctor. It helps me connect with my patients more, and I can get answers a lot more quickly and more accurately.
And Dr. Werner.
And I'm Sandy, and I'm muted. I'm Sandy Werner. I'm the fellowship director and the vice chair at Metro Health Medical Center. And I'm with Lori on why I love ultrasound, but I also love it because it continues to let me grow. I keep learning more ultrasound as I go. So it makes me a better doctor, but it's also something that I continue to learn to do more and find more uses for it. And that's another reason I really love it.
And Dr. Jessica, I think you're a panelist today as well. I'll let you say your last name.
Yeah, I'm Jessica Baez. I am one of the ultrasound faculty members at the University of Cincinnati and an APD for our residency. And for me, I love ultrasound because it sort of combines my two passions of clinical care for patients and helps me optimize that, but also education of learners of all kinds.
All right, thank you. And Dr. Alex, I'll let you say your last name.
Sorry, I forgot I was muted. I'm Alex Pavandy. I'm currently an ultrasound fellow at Wayne State University in Detroit through Sinai Grace at the moment. What I love about ultrasound is there's a lot of things, but I think mostly just how much information I can gather in such a short amount of time. And it's so much easier to share with my patients and also my clinical team to kind of help us guide resuscitations and treatment. So there's a lot to love about it.
Thank you. And Dr. Poland.
Hi there, I'm Scott Poland. I'm from Suma Health System, where I'm the ultrasound director. And then I also oversee the system's ultrasound point of care committee as the chair for that. Something I love about ultrasound is that it allows me to spend a little bit longer with my patients. And so I get to kind of be at the bedside, kind of have conversations with them and kind of see directly into their body, even though it may be 50 shades of gray.
All right, and Dr. Jones is our candidate young physician chair, if you want to say hi.
Hello.
And
Is that
then
good?
let's see, our last panelist, but not least, is Dr. Cray.
Hi, I'm Cray Bolger. I am the Fellowship Director at Ohio State, and I am our Associate Division Director. And I will try to come up with something unique since everybody else, I agree with everybody else's points. I really think it does help your patients not just be told what's going on, but really be part of the process. I can remember a case of like a little old farmer who had like a 5% EF, and he's like, I'm going home. It's like, you're going to die at home. And so I sat there and I was like, my heart, your heart, my heart, your heart, until he kind of like grasped the concept of what was going on. I think also it's one of the things that really interfaces with all the aspects of medicine. It's administrative, it's clinical, it's educational, but also it expands like beyond our department. It's not just an EM thing. Like I'm actually right after this giving a lecture to EMS providers on ultrasound in cardiac arrest. And so I think, you know, it's one of those things that really is like a universal language in medicine. And so it gives you a lot of flexibility. You can pivot at any point in your career to really figure out what you want to do with it.
All right, I think is that everybody, Holly?
Yes, I believe we got all the panelists. And just as a reminder, it is being recorded. So this will be sent out to all of our residents. So everyone will find it informational.
Okay. So I think that brings us into our next question. Why pursue an ultrasound fellowship? Why would you suggest it to residents?
Since I went last, I'll go first. I think especially for residents who are interested and maybe they don't know if they want to do academic or community medicine, I think this is one of the fellowships that really is applicable. Like you can find a niche in either role. You know, if you're the community person and you say, hey, I'll bring this ultrasound program to you and fellowship trained, I'll help you set up image archiving and documenting and bring in revenue, like you're like way at the top of that pile from a candidate standpoint over anybody else who wants that job. If you're like, I never want to work in the community, I want to like live my little academic world. Like there are so many untouched areas. Like I think we're just like at the tip of the iceberg as far as like what you can do with ultrasound. You know, like we haven't started doing transcranial Doppler yet in ED, but I am all for it. Like there are so many different things you can do with it. And so many different specialties who are just like scratching the surface. And so I think it's one of the things where you're like, there's just endless possibilities. Like if you can come up with an idea, there's probably somebody who will support you in the ultrasound field. So I think it's a great way to really define yourself and not just follow somebody else's track, but you can even make your own track regardless of where you think you're going to land.
Yeah, I agree with Cray. And I think it makes you a better doctor, which is one of the things we've all talked about. And you get some of that in residency. But, you know, if you really want to be the best you can be, I think ultrasound is a great path to take. And I think it's a segue to other leadership roles. I mean, you may start out in ultrasound, but then, you know, you may find that you're chairing the system-wide POCUS committee, and then you're doing other administrative things. So I think it can really lead you on a leadership track, and it may not be all ultrasound, but it's definitely a great jumping off point if you're interested in administrative stuff or education. I mean, like Bob Jones went from the ultrasound fellowship and division director, and now he's a assistant dean at the university. So it's just a great way to start your leadership career.
And I just wanted to segue on that as well. And kind of what Cray had said is that that multiple nature of the work and of the fellowship allows for a lot of flexibility in your later career also, right? Like Cray was kind of saying that you can come into a job with lots of different skills, but then you can also reinvent your job as the need arises. As your residency program needs more education, you've got that. As your hospital needs more ultrasound administration and attention to billing, you've got that. So it allows you to be flexible to what the needs are at your institution and when you change institutions or change jobs. It also keeps your job fresh so that you don't get kind of stale or bored at what you do.
Yeah, I'd like to echo that. I agree. As kind of Sandy mentioned, I think it provides a niche that you can continue to kind of educate yourself, stay fresh on topics, and it kind of allows you to be the expert at your facility under that, whether that be in the community or academic setting. And so people look to you. It does give you that leadership role. And as mentioned, it kind of allows you avenues into more of an academic setting, more of a research setting, more of an administrative setting. So you can kind of pick and choose, as I mentioned, kind of throughout your career, what really appeals to you and what provides you meaning.
To kind of add to what everyone else has said, I totally agree with everything. And I think it also opens, I know this has kind of been touched on a little bit, but I think it opens a lot of doors. For me in particular, it opened doors from an education standpoint. Like I'm in residency leadership now, and I don't think that would have happened had I not really been very involved in ultrasound earlier on. And then I think another thing that, like for me, one other thing that I was really interested in was global health, and it really gave me a tool that I can go abroad and immediately apply it to patient care. And I thought that was really rewarding, and really, it was just a very easy way for me to get plugged in once I was there. Whereas if you go there and try to start a program or start other things, it's a little bit more challenging, but now you just have a very tangible tool that you can offer and immediately improve the care of patients there. So I thought that was really cool.
I think one of the things for me that I would definitely recommend was, I wanted to teach and I wanted to be involved with academic medicine. And so, one of my attendings asked me, he's like, well, what do you love to do? I was like, well, I love to do ultrasound. I said, all right, we'll teach that. At pretty much any emergency residency, there has to be like a core ultrasound something for the residents. And so it's a wonderful niche to get into. But I would also say that I kind of split my time now between a fellowship and then kind of doing some moonlighting at a community site. And it has been just an immense tool to help me get through my shifts. Like, for example, we always had DVT or ultrasound DVT coverage, so we could order that test whenever we wanted. And then a couple months ago, our hours got cut significantly. And the plan was then sometimes to either, discharge these patients on an anticoagulant or have them stay in the observation service. And I can do that on my own now. And it just increases throughput throughout the department. There are so many things I don't have to send a patient for down to the ultrasound suite or radiology suite to have this done, or, God forbid, be admitted to have a scan done or something like that. And it's made my life a lot better, my work a lot better, and therefore my director's a lot happier. So it's doing an ultrasound fellowship, to me, whether you're getting into academic medicine or community medicine, will not hurt you at all. It will only benefit you. And once you really get into it and realize how much you can utilize this tool so rapidly, it's just fantastic. And it just, like I said, it makes the shifts better. It makes me feel happier knowing what I'm doing. It's just kind of a very helpful tool. So it's a fantastic thing to get into. Highly recommend it.
That kind of is also a perfect segue into my next question, which was, how do you guys feel like you incorporate ultrasound into your practice? Is it more an academic thing? It sounds like Dr. Pavandi is using it a lot in the community. So how do you guys feel like you are incorporating it into your everyday life?
Well, I'll start this one. Just I would say, it definitely kind of depends on the patient, but where I am right now, any patient that's somewhat unstable, they bring to their resuscitation bay, and we start there. And I've been encouraging my residents there to really perform whatever ultrasound they think is appropriate on those patients. So if they're chest painters, obviously they're getting cardiac, they're getting ultrasound. We're going to take a look at their aorta. And it has helped us so much, not necessarily come to like a complete diagnosis, but at least guide our resuscitation and guide our diagnostics. And it takes 5 minutes. So that's one of the biggest things I would say. The other thing that I use it for quite a bit more now that I'm getting more comfortable with it is in kids, especially kids with like, or respiratory complaints, that kind of thing. And I can, first of all, they love ultrasound. The kids love it, and you can show them their little heart beating and they just think it's adorable. But also discussing with parents like, oh, this is what, I think this could be pneumonia here, and, you can spare them the radiation. But also in anything that I would normally send a patient for a scan, I can usually do that myself, other than usually like a transvaginal exam or something like that. And it really helps me connect with the patients, and I think they appreciate it quite a bit. So I would say, the day-to-day things, you can use it for almost anything, but especially for resuscitations or unstable patients, it really, really helps guide you into what you need.
So I work at a facility that kind of is a merge between, we have a tertiary center and then community centers. And so I think how ultrasound is used at those two facilities, I think really varies. Is something I've appreciated. One thing we've really been working on is changing the culture of ultrasound. Previously was mainly just academic. Now we're trying to get it to be used more in the clinical aspect of their medicine. And so there I really see it helps, I agree, in kind of the resuscitation type medicine, narrowing your differential, focusing your treatment, and then guiding procedures. Where kind of in the community or rural setting, or more of the community hospital, it's very useful for even a broader standpoint, because you don't have radiology ultrasound available. The one place I work, CT scanner takes a 15-minute walk to the old part of the hospital that's closed. And so you really can you need to use it to really provide the best care for your patients. And so it's interesting because it does vary, I feel like, in the rural versus academic setting. And one thing, like I said, we're working on trying to change that culture from just purely academic to using it more clinically.
I think one of the cool things that I have found in the era of boarding, at least at our hospital, there's this big push to minimize, consultants as much as you can, if not necessary, and CT imaging. And it's a really cool tool that you can use to look at things without a CT scan, and potentially save a consultant if you can use ultrasound to diagnose something or do a procedure that maybe your consultant will do. And so I found that with my practice, that has made a big difference in that. It also makes you the cool attending when you can do an ultrasound guided procedure that someone wouldn't otherwise do necessarily.
I think outside the academic realm, like another arm of ultrasound is billing. Like I know that's like the unpopular thing to talk about, but I think it is like we would all like to pretend we would do this for free, but the hospital would not exist if we all did our jobs for free. And so I think just demonstrating value, both to the hospital and to your leadership, is really important. Like during COVID, like people weren't coming in and doing tests, right? So ultrasound was like the last man standing, and like we kind of maintained a nice steady stream. And I think that is an important thing, especially if you are going into the community. If you decide not to do academics, is demonstrating the value of it. It's obviously wonderful for patient care, and we want our patients to get the best care, but if it's adding value to your department, so your department can stay open to serve those patients, like that's a huge thing. And I'm sure all of you are loving the new documentation system. And this was a big debate on our fellowship collaboration meeting yesterday. But it seems that it by itself, like there's what it brings to your department, but it also brings value to the hospital. Like they get about 3 times at least what we get in our department for technical fees, which is huge when you're trying to demonstrate your worth or a position at the hospital, or the need for a new machine is like, what are you bringing back? And so I think it's a very valuable clinical skill, not just diagnostically, but also administratively, where you can really be an integral part of your healthcare administration team. So if you're like, I like it, but I'm pretty sure I'm going to land in the community, so why should I do a fellowship? You don't learn any of that during residency. Like, we don't teach you about like the nitty-gritty details of building during residency, and that is a core component of fellowship, which I think is really valuable, is like establishing and running a program, because you may not live forever in the academic setting, and you might not stay at a place that has a program. And so knowing how to set that up, that's a huge like value added to any department. I know it's the unpopular thing to talk about, but
I think I use it in my practice. We have the main ED, and then we have several community EDs, and they're pretty much freestanding. And I use it for, diagnosis and procedures and training. So mostly a lot of training at the main hospital and a lot of, or just education, and then out in the communities, a lot of diagnosis and procedural stuff. But I also think it really helps you build bridges with other departments as people are starting to do ultrasound. You really get to work with people. I mean, we have a great relationship now with our cardiologists who, they like that we're doing ultrasound, and they're very happy when we can identify a pericardial effusion with tamponade in the community and say this, I'm sending you this person. And they look at the ultrasound and say, oh yes, please do right away. So it really kind of helps you collaborate more with the other departments and build bridges, which I think is just a really great part of ultrasound. And I like that about having it in my practice.
Just to echo off of that, it's been really kind of amazing for me the past couple months when I showed up at this community site where nobody really liked ultrasound that much use in the emergency department. And now I have one very crotchety general surgeon who loves it when I tell him what's going on based on ultrasound. And I've had a couple times that he'll just admit a patient based on what I've done to get through. I've got a very, generally speaking, angry cardiologist who has accepted a couple patients just based off of my echo findings. And then the internal medicine service where I'm doing fellowship now has been really interested in what we do for resuscitations and also guiding like fluid resuscitation and that kind of thing, and teaching them that, fluid is not always the answer for everything. So it's been, the use in the ER is great, but when you can actually reach out to these people that a lot of times people thought were kind of untouchable, it's been really rewarding. So, and it happened in just, a couple months. So thankfully that's been really wonderful.
Yeah, to kind of go along with what Alex just said, I think one way that I like to use ultrasound is to help advocate for my patients. If a consultant is not really, buying what you're saying, or, their team's a little bit, they're hedging a little bit, sending them an image, an image speaks 1,000 words. And I think sending them an image can sometimes advocate for a patient in ways that just talking to the consultant may not accomplish. So that's one of the ways that I like using it. And then I think from a clinical standpoint, purely, I think ultrasound is incredibly helpful in your undifferentiated patients. And it can really help, can really narrow down your differential from something that's huge to just a few things in a matter of minutes. And I realize how much sometimes I take for granted how much I use ultrasound. And then this really stands out in my mind. But a couple of weeks ago, when I was doing one of my community shifts, we have one machine in our department and it was down. And so I had to work my whole shift without it. And I realized, there was so many times where I was like, oh, I wish I had my ultrasound so I could, look for B-lines or see what their heart looks like. So I could, determine how much fluids I should give. And so it's just such an invaluable tool at the bedside that we can really use to change management of patients within a matter of minutes without any other diagnostic testing back.
All right, shifting gears a little bit, Dr. Jones had a really great question that I wanted to discuss about the new ABEM designated focus practice for advanced emergency ultrasonography. he was getting a lot of questions from residents about this. Can they get this designation if they don't do a fellowship, or if they do a fellowship?
I can field that as a UFAC human. So at this point, no. At this point, you have to have your fellowship training to sit for the certifying exam. It'll be offered every 2 years, and you have to do it at a fellowship that is accredited before your graduation date. So you go someplace and they don't get accredited, or they aren't accredited when you start there. If you graduate on June 31st or June 30th, sorry, calendars are hard. They have to have their accreditation prior to June 30th. So if they get it July 1st, it doesn't count. So that's a really important question to ask yourself when applying to programs, is if this is valuable to you, especially if you're planning to be a director somewhere, you may want that certification behind you that you sat for this exam. It's not like it was developed by an outside body. All of these, both the fellowship requirements as well as the tests, were developed by people within the field, emergency medicine people within the field, which makes it different than any other exam that's out there. And this is really to give like structure and consistency. The intention of it is to make sure that the fellows are getting a universal experience that is at a standard kind of set by the community.
Craig, do you know how many of the current fellowships out there are accredited?
A lot. I would say over 100. I know we've done, I would say almost 120. If I have to, like I would say it was about 120. But the UFAC site has everybody. So if you just put in EUFAC, that will pull up the site of all the accredited fellowships on there. And similar to ABEM, because it's kind of a parent company of ABEM, it will have, or parent organization of ABEM, it will have eventually their accreditation status, how long they're accredited for. You can see their accreditation history, similar to like if you were going to an ACGME fellowship, that you would see, are they active? Have they had any penalties in the past? So there's going to be a lot of transparency for fellows with that. Thanks, Laura. For that. We don't have a ton of new programs coming through right now. It's a lot of re-accreditation, but there's a handful trickling through.
And I would say that, trying to get the focus practice designation, the only way to really do it is with a fellowship. And you want the fellowship, you want that teaching, you want the insight into the programs and the hospitals and the billing and everything else that we don't really get to experience or learn about that much in residency. So if you're definitely thinking about doing this, obviously go through the fellowship, because it's worth so much more than just the focus practice designation, I think.
Yeah, and I think as we go forward, it's going to be more important when people are looking for even ultrasound directors in the community. Now that we have this certification or this extra thing under ABEM, I suspect that directors will be looking for that when they go to hire somebody who's going to run their ultrasound program, whether they're academic or in a community setting.
And then I guess the last question I have before I open it up to the other residents is, I think most residents have this in mind, but what is the job market looking like for someone who's completed an ultrasound fellowship? What was the process like finding a job afterwards?
Well, I finished my fellowship in 2004, so I'm not really going to speak to this one because I think it's totally different now.
I can speak a little bit to it. It was, so there's kind of two aspects for me. So one, my residency has ultrasound curriculum, but they're working on expanding it quite a bit. So I was able to get rehired there pretty quickly. So, but the other side of it is that where I'm going to be doing that, I will be working primarily in a community setting, and then going to teach a little bit on the side, essentially. And then where I am in the community setting, having that ultrasound fellowship under my belt put me ahead of a lot of other candidates, because that community site didn't, it had an ultrasound machine essentially, but that was about it. And so the plan now is to kind of help teach the other attendings, teach the nurses, and sort of get that established there. So bringing that to the table for me was a fantastic asset to have that probably helped land me the job. So.
I can't speak for myself because it has been a long time, but I've watched several rounds of fellows go through the process of getting jobs after their fellowships and how that has gone. And my overall sense is that there is no dearth of jobs. The community sites are becoming a lot more savvy about the need for ultrasound for patient care, and also the need for continuing education, and how some of the older physicians got missed in this gap between, how ultrasound was taught in residency. And then there's also the need for billing. All of these departments are, everybody's kind of trying to scrimp and save right now. And ultrasound is a way to boost what we are already doing and capture what we're already doing with our billing. So I have seen a lot of fellows go directly into ultrasound director positions in the community. Also, I've seen most of these places that are academic, there's turnover, and a lot of people like Sandy and Bob Jones, like people are moving up into other positions. And so the ultrasound positions need to be filled, and more positions are being created because system-wide director positions are now becoming fairly standard and are very often run by an emergency physician, maybe in concert with somebody else within the hospital that does POCUS. So from my perspective, there's always this worry, oh, we're saturating the market, but I haven't seen that happen yet.
I would agree with that. I think it mirrors just the job market for emergency medicine kind of at the baseline. I think the workforce study isn't 100% accurate, but there is some things to take from that in the sense of, I like to say you can either pick location, pay, or lifestyle, but you can only pick two of them. I think that's kind of the same idea, is that you're going to find a job. It may not be, say, in the location that you want to go to initially, but it may have the pay, the lifestyle, maybe say an academic with a good pay, but not at the city or state that you want to go to initially. I think eventually you can work your way there. But I think just being realistic, the same with when you graduate residency, the same type of thing. I think there's certain areas that it's going to be tough to get a job. If you're going to Austin, Texas, I mean, it might be a tough place to get a job, or Denver, Colorado. But if you're open to just picking two of those, I think realistically you will find a job. There are jobs there. I don't know if anybody else, but I feel like I get recruiter messages all the time.
I would echo too what Lori says. I think the beauty of an ultrasound fellowship is it doesn't pigeonhole you into only academics, and it gives you a very diverse portfolio potentially, and it gives you a leg up over other candidates. So like we're recruiting for general clinicians right now, but if you have a fellowship and I can use your skills somewhere else in our residency or our program, like you could be an educator, you could be administrative. It's really interesting. I'm doing the chair development course right now, and I think there's 3 ultrasound people there, and they're like, this is so weird, all these ultrasound people. I'm like, we're perfect. Like, you have a little admin, a little education, and a clinical skill. Like, we're going to take over the world, clearly. And I think that just speaks volumes to the versatility this fellowship gives you. I would say one thing as residents, which we haven't talked about yet, that I think is important, is preparing yourself for fellowship. If you're choose right now, this is your optimal time, if you haven't started this already, to like think about which of these tracks we're kind of all talking about, like, is what better suiting for you. And I will say fellowship itself has gotten much more competitive. Like before, we would interview like 3 to 5 candidates. Now I'm interviewing like 15 candidates for a handful of spots, like 1 to 2 spots at most places. And I think as people get accredited, your volume of fellowship spots is going to go down because we're going to have specific ratios that people have to meet for faculty to fellow spots. And so just keeping that in mind, like some people will do a fellowship because they want to land in a location and they're hoping this gives you like an in the door. And I would say as fellowship directors, we're very aware of that. Like, you're not sneaking past us. Like we know that's what's happening. Like if you're like, I love teaching, and I look at your CV and you've never taught a course in your life, no. So I think it's not saying you have to do like NIH grant funded research, but I think your CV should reflect your ultimate goal, which does mean starting in your first and second year of residency to build that CV. Like, you can't just start all your projects in August of your 3rd year, the week before you apply for fellowship. Like, that's not going to fly anymore. And you can have an empty CV, but you're not less likely to be in the top of our rank list if you do. And I've seen people fail with their ultimate goal because they were like, I'm going to do an ultrasound fellowship because I want to land in this desirable location. And they only applied to one program. Like, you can shoot your shot. You're probably not, it's not going to work typically, because that place probably has 20 other people who not only want to be there, but want to be there and have something to bring to the program. They're not just coming as a pre-interview year. And I think that's been a big change, and I will defer to the other fellowship directors, but in the last like 3 to 5 years, where like I have a lot more choice as a fellowship director, and I don't just have to pick any warm body to fill a seat. And so I think that requires a lot more premeditation on the fellowship candidate of like, are you picking the right program? Because I guarantee each of our fellowships are a little bit different. Like, Lori's going to do a lot more global health exposure for you than I will, but I will, like, you can teach any human at any level with me that you want to teach. And I think knowing that about your fellowship, like, what's your long-term goal? And does this fellowship have the people and the track within it to support my long-term goal?
Well, those were all the questions from me. I want to thank you guys so much. And then I was going to turn it over to anyone else in the audience who had any questions.
Hi, I did want to ask a question. I'm John. I'm one of the residents at Akron General. Dr. Buller kind of answered it, but right now I was wondering, what are you looking for in an applicant when the application comes on your desk? And what could I do right now to prepare more for fellowship?
I can answer this one because Craig talked about it some already. So from my perspective, I don't want to push anybody off of the list just because you didn't start really early with ultrasound. I was one of those people who, like, I decided on EM like at the beginning of my 4th year of medical school. I decided on an ultrasound fellowship in July of my final year of residency. So I have a lot of empathy for late deciders. But your portfolio should be pretty well-rounded, because people that go into an emergency ultrasound fellowship, you have to have a lot of different skills. So something in the realm of research, because you're going to be required to do some research, something in the realm of education, and preferably something that you've led yourself, because ultrasound fellows do a lot of designing their own program for education, like running a workshop and coming up with that. So seeing that you have those skills, even if it's not an ultrasound, is really, really important. And then also, you know, your references from people and how hard you work during your residency program, how you have interfaced with others during residency, that speaks volumes. That is one of the best predictors for me of whether or not you're going to be successful, because I can teach you so much, but if you're not willing to learn, if you have lots of like difficulties staying up on administrative tasks and like answering emails, then those are the things that I try to ferret out before you start a fellowship program, because I want anybody that does a fellowship program to be very successful.
I agree with Lori. I think like I had some late deciders this year, and like they were just honest about that when they applied. And so what would happen is the fellowship director would call me and be like, hey, their CV is not like, I love them, but their CV doesn't support like this. Are they that person? And I'm like, absolutely, they're that person. They just came to this late in their residency. And like making friends with your fellowship director, like if you never talk to me and then go apply for fellowship and then I get this phone call, like what am I going to say? So as your fellowship director, even if you don't want to stay at your home institution, like phone calls are going to come to your home institution, because we're a pretty tiny community. And I would say like over half, like we can find each other even if we don't know each other, and we're going to make a phone call and say, tell me about this person. Like as Lori said, are they teachable? Are they a hard worker? And if your CV is not like robust, are they somebody who's going to show up and do the work? And are they really serious about this? Or is this a way to get to a location? And like as Lori said, it's okay to be a late decider, but be honest about that and like try to come up with a plan going forward. Like I met with each of my people who matched this year probably 3 to 5 times from like June to August, saying like, what are you going to talk about during your interview? And like, how are you going to sell yourself? And like, what is your long-term goal with this? Like, and it can't just be like, I like ultrasound. That's cool. Like you can like ultrasound, but why are you staying poor for an extra year? Like, what drives you to want to do this outside of your general EM career?
The the other thing I would kind of add to that is as a applicant, you know, a huge part of what you're going to be doing obviously are your fellowship responsibilities, which is going to be, you know, you're going to be taught, you're going to be expected to teach residents and medical students a lot. You're going to have research responsibilities. A lot of it is going to be self-driven, but the other thing that's I think pretty important to realize is that where you're going to be most likely, that place will expect you to act like an attending as well. So you're going to be working, like right now, I do between 5 and 8 shifts at my institution a month. They're, you know, 8-9 hours at a time. But at that place, you also might be expected to, they might be solo shifts. You might have residents underneath you or other students. And so I would say, you know, be prepared to be an attending. They're going to probably start you on it right out of the gate, and then, you know, be prepared to teach a lot. And if teaching is not one of your strengths, might want to work on that part, because that's real important for the fellowship.
All right, it looks like Dr. Curry has to head out. I wanted to say thank you all again. If anyone has any other questions, you can shoot an email to me and I can send an email to whoever you need to have that question answered by. Thanks again for coming. Holly, is there anything else?
Nothing else. Thank you for joining.
Thank you.
Bye-bye.
Bye.